Hi, everyone. Welcome to our webinar. We wanted to let you know at the top that we have Spanish translation available today. So everyone should actually go to the translation button. It looks like a globe at the bottom of your screen, and you'll select either the English language channel or the Spanish language channel. And once you've done that, we should be ready to go. We want to welcome you to our webinar today. Today, we're going to be sharing with you an overview and main takeaways from our collection of papers, which came from a scoping review on the economics of abortion. This has been a collaborative effort, which was commissioned by IPAS and done in partnership with colleagues at the London School of Economics and Rutgers. Next slide, please. We're going to start with some introductions of all of our speakers today. I'll start with myself. My name is Sherry Poss. I'm Associate Director for Program Evidence at IPAS in the United States. And I'll hand off to Ernestina.
Thanks, Sherry. Hi, my name's Ernestina Coast. I'm an academic at the London School of Economics, and I'll pass the mic to Jana.
Hello, everyone. I'm Jana Rogers, a professor at Rutgers University with a training in economics. And I will pass to Samantha.
Hi, everyone. I'm greetings from Berlin, Germany. I'm Samantha Ladoff, formerly of the London School of Economics. Now I'm CEO and co-founder of Mila Health. I work to improve maternal and newborn health by bridging research and technology. Over to you, Sherry, or Brittany.
Hi, everyone. My name is Brittany Moore, and I am an advisor with the Scientific and Technical Division at IPAS. Thanks for joining us.
Great. Thanks, everybody. So today we'll be providing an introduction to our collection of papers on the economics of abortion. We're going to start with the methodology for the scoping review. We'll then highlight some of the key findings at the micro, meso, and macro level, which will be led by the lead author for each of those papers. We also had a secondary objective for this work to look at the links between the economics of abortion and stigma, and we'll touch base on those findings as well. And then we'll wrap up with some of our main conclusions from this work. Next slide. I want to start by talking about why we undertook this project. We at IPAS wanted to understand the evidence base on the issue of the economic outcomes of abortion access and policies. From the work we do, we know there are economic implications of abortion at the individual, systems, and policy level. We often think about these implications in terms of costs, but we know from our work there are broader economic impacts beyond cost, and that there are even economic benefits and value that come from abortion. But we had never seen this framing of the evidence on the economic of abortion looked at in a systematic way. So we put together this partnership with my fellow researchers to help us do just that. And our key objectives for this were to provide medical professionals, healthcare providers, advocates, researchers, policymakers, and other key stakeholders with systematic evidence on the economic implications of abortion. We wanted to synthesize the knowledge base in the social science literature and focus on the impact of abortion-related care and policies across the safety continuum. Next slide. For this scoping review, we used a search process based on a protocol following the Preferred Reporting Items for Systematic Review and Meta-Analyses, PRISMA, extension for scoping reviews. This helped to ensure the review was manageable, transparent, and reproducible. The search included any referred journal article with qualitative and/or quantitative data on abortion-related care or abortion policies. The search yielded 19,653 unique articles of which 365 articles were included in our final inventory for data extraction. More information on our methods can be found in our published protocol. Next slide. To be included in the review, articles needed to include information on at least one of the following 4 types of economic outcomes: financial cost, which is the cost of receiving or providing abortion care or financial costs resulting from abortion policies; impact, the effect or influence of abortion care or abortion policies; benefit, advantages or profits gained from receiving or providing abortion care or implementing abortion policies; and value, the importance, worth, welfare gains, or utility of receiving or providing abortion care or implementing abortion policies. Next slide. We analyzed each of these outcomes, costs, impacts, benefit, and value, at 3 different economic levels: the microeconomic level, which includes abortion seekers and their households; the meso-economic level, which includes communities and health systems; and the macroeconomic level, which includes societies and nation states. Next slide. Among the 365 studies included, an overwhelming number examined the United States. Almost 1/3 of all studies focused exclusively on the United States, and an additional 7 studies on a selected group of countries included the US in their analysis. The dominance of the United States in the studies of abortion not only reflects the political attention focused on abortion, but also the availability of data, the institutional affiliation of the authors, the editorial home of the journals, and the location of funding and other resources for conducting studies. After the United States, the country with the most coverage in the final inventory of studies was the United Kingdom, followed closely by India. Substantially more studies focused on African countries relative to countries in Asia, which is interesting since there's far larger population in Asia. Relatively few studies focused on countries in Latin America and the Caribbean, most likely because abortion policies are more restrictive in this region than any other part of the world, which may also present obstacles to researchers. Noticeably absent, with just a few exceptions, including Egypt, Iran, and Israel, are countries in the Middle East and North Africa. So with that background on the scoping review, I'm now going to hand it off to Ernestina to dig into the findings at the microeconomic level.
Thanks, Sherry. So to sort of set up my few slides, we know that inequitable and unjust distribution of economic power is a critical determinant of health. And in this micro piece of the work, we want to understand how the microeconomics of abortion are distributed unequally within, but also across populations, which means that we can ask and try to answer really critical questions like, how do the relative costs of different kinds of abortion care seeking impact on decision making about the type or the timing of care? Are poorer people more likely to seek less safe abortion if that's cheaper, or because the costs of safer abortion care are beyond their reach? And it also allows us to start to frame questions like, how and in what ways do the economic consequences of care, or the anticipation of the economic consequences of care, affect the timing, the type of care sought, and longer term consequences? And what was really interesting about the micro piece that I'm presenting on, which is that although relatively few studies are defined explicitly by their authors or by their methodology as being explicitly economic studies, our review shows that there is a lot of economically relevant information that we can glean out of the existing evidence base. Yes, there are substantial evidence gaps and they're persistent, but there's a lot more information out there that isn't necessarily defined as economic in its scope. So on the first slide, thinking about the costs, well, it's not going to come as a surprise to anybody that seeking abortion-related care has frequently substantial costs for individuals. And this is in many ways most clearly demonstrated in the evidence base from settings where abortion care is theoretically free of charge, but where to seek or acquire that care involves substantial direct or indirect costs. We also saw the way in which in some settings that conditionality of care was linked to costs. So for example, a case from India where abortion services in the public sector were provided for free only if the woman or her husband accepted some form of contraception, usually sterilization or for women an IUD. And in contexts where somebody has to make multiple visits or multiple referrals, these costs are multiplied. The evidence base around indirect costs, which are substantial, is often unclear. And in facility-based studies, there tends to be a really narrow focus on the costs of getting to and receiving care at the facility. And the evidence base shows that there's a much broader range of expenses and costs are important. It's a huge range. But travel costs appear to be the most frequently cited indirect costs at the micro level in a really wide range of contexts. Next slide, please. So if we think about how people go about getting the resources to cope or to deal with the costs, a really wide range of resources sought for costs. What was also interesting was looking specifically at interventions in very different contexts, ranging from informal practices like the provision of free services on a case-by-case basis in Ghana, through to informal community support systems in Myanmar for transport, through to more formal clinic loan arrangements, so credit arrangements in Australia, things like sliding fee scales, but also, for example, funds in the US, abortion funds in the US. We see a really clear intersection between costs or anticipated costs and the type of abortion care seeking, because in many contexts, we see that actually the costs of post-abortion care where it's needed are more expensive than safer abortion care. And a really strong thread throughout a lot of the studies was the ways in which costs were implicated in delays. And this is a really important thread to keep pulling through, because if we are able to identify and unpack the points at which information and services might be better designed to reduce the delays and the ways in which these intersect with economic factors, we can much better understand how health systems and specific contexts reproduce injustices and inequities. So, for example, we know it's often poor individuals who are least likely to be able to navigate or get over economic barriers to abortion-related care, and there are therefore greater delay implications. Next slide, please. We see an intersection at the micro level between costs and gestational limits. Evidence from Australia shows how at later gestations, the abortion costs increase and how that crosses thresholds at different gestational ages. We also know that the indirect costs from evidence in the US may lead to greater travel costs associated with obtaining abortion at later gestational age. And we see, particularly in places where there are mandated waiting periods, that show that waiting periods that mandated multiple visits have substantially higher time costs imposed by these sorts of restrictions, which may actually alter pregnancy outcome. Next slide, please. We see that in some contexts, less safe methods are cheaper, in some cases substantially cheaper than safer methods. So it's about thinking about the relative costs, but importantly thinking about the ways in which at the micro level we can think about the benefits and values. So here we're talking about the advantages that are gained from or perceived to be gained from, or the importance to an individual of receiving abortion care. There's very limited evidence base outside of the US for these sorts of aspects of economic impact of abortion-related care, but where there is evidence, it tends to show positive outcomes for women who are able to access financing for abortion-related care. Next slide, please. If we think about the ways in which obstructions to care are both defined, enforced, and understood by providers, how those obstructions, barriers, refusals to provide care are communicated to women, we can see how, even in contexts where abortion is legally available, this can lead to significant delays in care and increased costs in care, particularly where in contexts where people are unable to negotiate with, for example, a formal health system. We can also see how the ways in which policies that restrict who can provide, or where the provision becomes more and more restricted. Again, this is evidence from the US that shows that, unsurprisingly, in contexts where facilities closed, more women spend more time and more money to secure an abortion than they would have done if their local clinic hadn't closed. And an important piece to this evidence base is that this also is linked to requiring much more disclosure in order to secure the care that women were seeking. And if we look at the interplay at the individual level between the criminalization of abortion care and microeconomic costs, we see how providers can exploit concerns, fears about criminalization, and exploit, for example, for fees that shouldn't otherwise be charged. And we can also see the way in which care seekers themselves, their fears and perceptions of the legal consequences can be further exploited. And there's quite a lot of evidence here from countries as diverse as Mexico, Ghana, Zambia, and India. So that's the end of the headline of the microeconomic outcomes and impacts. I'm going to hand over now to Samantha, who will be looking at the next level. Thanks, Sam.
Thanks, Ernestina. At the Meso-economic level, we examined 150 studies that reported on the multiple channels through which abortion has economic effects on health systems and communities. But only 2 of these studies looked at communities, so we're really just looking within health systems. Like the microeconomic studies that Ernestina discussed, we have lots of cost data. 3/4 of the Meso-economic studies reported data on costs of abortion within health facilities and health systems. And we see from these data that the costs of providing abortion services vary greatly. So some researchers specified all of the direct and indirect components that are involved in the delivery of abortion services and costed each individual component for determining the total. Others didn't. And so there's just a great range in terms of how these services are identified and costed. And yet there are a number of commonalities that we observed related to cost that will come through more clearly in some of the themes that I'll discuss, starting with financing. So numerous studies reported that the treatment of post-abortion complications consumed a significant proportion of health system resources in many settings. And these costs are really a burden to health systems because they're requiring a disproportionate amount of health facility resources. So if the health system is already stretched, having to pay for these services is just overstretching already limited resources. We also saw a lot of studies talk about how decentralizing services and legalizing abortion can produce substantial financial savings for the health system, making it easier to meet demand for services and to provide quality care. It is even possible to maintain or improve the quality of abortion care services you're providing while achieving financial savings at the same time. It's difficult, but possible. Turning to criminalization, the studies here generally showed that costs to health facilities are higher in locations with patchwork abortion laws. So, for example, there were abortion reforms in Mexico's federal district that led women from other states to come and seek legal abortions there. And as a result, the facilities providing abortion services experienced increases in both their workload and costs. Criminalization also impacts costs to health systems, as it requires significant resources from health systems to treat complications from unsafe abortion. So here, there are some good financial models from Uganda, for example, that showed that moving from a setting where abortion was conventional and legally restrictive to a setting where abortion was planned, decentralized, and legally permissive actually decreased the mean cost of a per unsafe abortion complication case by 86%. So it was a really significant savings for many of the facilities providing care. Next slide, please. Moving to task shifting, the studies in this group showed that shifting simpler procedures to lower level hospitals or primary clinics or to midwives and nurse midwives could help minimize costs where possible. But it is important to consider the setting and the context when you're assessing the feasibility of task shifting. So there are logistical costs, financial costs, and these can raise facilities expenses in the short term. There's also some cadres of healthcare workers. So for instance, nurse midwives in Ghana who reported having less sustainable access to equipment than physicians. And those are all things that need to be taken into consideration when looking into task shifting. Amongst the studies that reported data relevant to universal health coverage, we observed that insurance companies provided coverage for abortion that was far from universal. So health insurance companies and public health systems effectively disincentivize abortion outright, or they disincentivize certain methods, which serves to restrict access to care. Even when policies exist to implement safe abortion services in the public sector, these policies can backfire if provider reimbursement is insufficient. On a related note, next slide, please, is obstruction of access to care. So this idea of incentives and reimbursement is closely related to studies that addressed obstruction of access. Some health providers used conscientious objection as a reason not to perform abortions in the public health system. However, these same providers would then willingly perform abortions in the private sector where the service was more profitable for them. Closely related to the task shifting theme are a group of studies that addressed the theme of provider restrictions. And so the data from these studies showed that requiring abortion to be performed by OBGYNs in hospitals led to higher costs of care and decreased access to abortion. And these types of restrictions, whether they're enacted through law or policy, can be quite costly for health systems and health facilities, especially in settings where task shifting could lead to greater financial savings. And finally, within the Meso-economic outcomes, we looked at studies around gestational limits on abortion and found that it does cost more to provide abortion at later gestational ages than at early gestational ages. But these costs can be further exacerbated by laws that are designed to make abortion more expensive and difficult to provide. So following the implementation of the targeted regulation of abortion providers or TRAP laws in Texas and the United States, for example, the cost of providing abortion at 20 gestational weeks increased by 37% compared to other states where that type of legislation had not taken effect. This is just an overview. There's more in the paper with the link that was in the invite, but we hope it's a good taster. And over to you, Jana.
Thank you, Samantha. And turning next to macroeconomic outcomes, you'll hear some overlap here with some of the themes covered already by Ernestina and Samantha. But in the case of macroeconomic outcomes, many of the effects that you were hearing at the micro and meso levels, we've seen additional studies, or sometimes within those studies, estimates of how those effects played out at the national level, at the societal level. So for example, in the area of financing, there are a number of studies showing that integrating abortion into a full set of reproductive health services has benefits at the societal level, especially in terms of total lives saved, as well as benefits to national governments for money saved, especially for not having to provide post-safe abortion services, post-abortion care. So the approach of integrating abortion into reproductive health services is more effective in terms of lives saved and more effective in terms of costs compared to a non-integrated salary strategy that does not have family planning and safe abortion services. And in terms of cost savings, one of the main reasons for this, again, is providing post-abortion care services. This is actually very expensive. It can be up to 35% of annual per capita income, depending on the country. And also restricting abortion access has negative spillover effects on women's educational attainment and labor supply. And these, again, are benefits and costs at a national level. We have seen evidence produced, for example, in the US with higher rates of high school graduation, college attendance, and employment, especially for Black women in states where abortion laws were liberalized. Next slide, please. Okay, you had heard from Samantha about task shifting. We have also seen these kind of estimates at the national level. And in addition to task shifting is also a shifting in the types of procedures that are now being turned to, especially in the area of medical abortion. A number of estimates have shown that that medical abortions are often considered the cheaper option at the national level, and more governments are moving to this approach. And they have, especially in the COVID-19 pandemic period. Our survey of studies did not extend to the last couple of years, but there's been quite a bit of research coming out, as well as media coming out, showing moves towards medication and medical abortions. Other countries, as Samantha mentioned, have been moving towards regulatory reforms that are allowing nurses and midwives to perform abortion in order to provide cost savings at the national level. Next slide, please. In terms of abortion law liberalization, we've seen quite a bit of evidence at the national level on what happens when abortion laws are liberalized. And study after study, again, is showing that at the macro level, we have an increase in women's educational attainment. More women are participating in the labor force. And we see a positive effect on the investment in children's education. So the next generation is being impacted. And in terms of methodology, some of the main ways that these effects are occurring is through what these authors are calling selection effects associated with abortion law liberalization. And that's why at a macro level, we do see positive effects for children in the next generation after abortion law liberalization. And there are a group of researchers who have been finding effects of abortion restrictions and showing what happens when children are born into households in which women were denied an abortion. And there we see a greater likelihood of those children being born into settings in which there's higher poverty, and the women have an increased need for public assistance. So these are studies showing, again, what happens when women are denied an abortion, and often that was in the case of the US because of gestational limits. Next slide, please. And finally, the other body of evidence that we were seeing at the national level was universal health coverage and the lack of public sector assistance for abortion care. It's very unusual to find countries that fully cover the cost of abortion care. Usually it's individuals who have to bear most of the financial costs. A few exceptions do stand out. Nepal, for example, has a set of safe abortion guidelines that includes free abortion services. In India, where abortion is legal, there are also free abortion services in the public sector, although some states have allowed public providers to start charging user fees. But overall, we are finding that by and large, most countries do not have public sector coverage of abortion care services. And the final point that we were finding in these studies on health coverage of abortion services is that at the national level, there are cost savings to having public coverage of abortion services. And these reduce the need for governments later on to spend on medical and welfare costs of pregnancies that would be carried to term among low-income women who were denied an abortion. And for that, with that, I would encourage you to look at the link that Brittany posted in the chat for the macroeconomics article. And we will switch now to talking about stigma.
Thanks, Yana. So I also just put the link in the chat for the stigma paper as well. So all of the articles included in our review were also screened for stigma content in addition to the review at the micro, meso, and macro level. And 1/4 of the studies in our collection contained information on stigma, but only 28 of those studies included stigma findings that were directly related to any of our economic outcomes. In these articles, we looked at the intersections between stigma and economic outcomes of abortion at each level, as seen throughout this presentation, and there are a few themes that are overlapping. So abortion-related stigma at each level was a critical barrier to services. For example, these were some of the key findings and results from this review. The ability to combine in a social support network has had an impact on available financial resources to access services. And the fear of being stigmatized by a partner or family members could result in women reporting fewer financial resources and a lack of support in seeking abortion services. In these cases, individuals seeking abortion services have to make a decision between their confidentiality, fear of being stigmatized by their social network, and having the financial resources to afford abortion services. In some cases, lack of financial resources and the fear of stigma from family and friends prevented some women from seeking abortion services entirely. Inadequate access to and sharing of information about abortion can lead to barriers accessing care. In some settings, individuals can find it challenging to find affordable and accessible basic primary care services with qualified service professionals. These barriers can compound when seeking out providers for stigmatized services like abortion or incomplete abortion care, as information around where to find these services and find safe services can be really challenging to find. Even in cases where care was subsidized, many lower income women were unaware of how to find these services and were not able to come into facilities or to go in for consultations. In the United States, there can be confusion regarding state funding both within and across state lines, as each state can have different rules. And these rules regarding abortion can jeopardize funding for each facility. We saw in an article that facility staff may be reluctant to provide women with information about abortion funding because sharing that information could threaten their state funding, facility, or livelihood. Abortion-based stigma can also lead individuals to seek abortion care outside of the formal sector. Pervasive community-based and perpetuated stigma can lead women to seek abortion services outside of the public sector, which can lead to exorbitant and unregulated service fees. So in some studies, we saw that providers outside of the formal sector capitalized on abortion stigma, using it to charge unofficial and illegal fees to women who were in desperate need of confidential services. Despite the legal availability of services, one study found that providers would refer to abortion services requested by unmarried adolescents, for example, as illegal services, and then were able to charge about 3 to 5 times the normal rate for their services. Refusal to provide abortion services or referrals can also result in substantial delays in care. So in one article, correct information was withheld by an insurance representative who refused to give information on coverage of abortion services based on their own personal religious beliefs. In another study, an individual was unable to receive a referral to a nearby facility that would have covered the abortion service under their insurance. Other participants in the United States, in a different article, were unable to get referrals from their doctors to receive abortion services in a hospital, which would have been covered by Medicare, which is the federal government health program, because of the doctor's personal beliefs. There are also anti-abortion movements and related political action that can restrict abortion access for women through legal regulation. So the individual decision to seek abortion services in the US has become, as we all know, a topic of public political discussion. So the anti-abortion movement has been able to remove abortion care from other aspects of reproductive health care and to shape the public perception of abortion as burdensome, immoral, and a socially stigmatized act. Anti-abortion movements have also led to the restriction and recriminalization of abortion in order to restrict access for women and to reduce public funding for facilities that provide services. So due to the restrictive regulations in countries like Poland and Ireland, for example, women must also travel outside of their country to access abortion services. So these were some of the key themes that we found in our review of the secondary outcome of stigma for the articles throughout our collection. We'll move on to the conclusion section where we kind of pull out the themes that are cross-cutting throughout our entire collection. So overall, the main findings can be shared outside of this meeting if anyone wants to email or connect with us, or you can read through our articles. We want to expand if you want to hear any more information about these conclusions or these gaps. So third-party authorization requirements can have a significant impact, particularly on minors. So third-party authorizations can be required by insurance companies, or they can be put in place by the government prior to accessing public funds for abortion services, serving as an additional barrier for individuals seeking care. As a result, unintended pregnancies can increase, or individuals may seek out abortion services outside of legal restrictions. Restrictions placed on who exactly is allowed to provide abortion services, including access to medical abortion outside of a clinic, can create a barrier to services through increased costs of service, as well as indirect costs of care, such as the costs involved to travel to specific providers or facilities. So the task shifting of procedures should be considered when feasible. Advocacy for universal health coverage that includes abortion and other sexual and reproductive health services is a key measure to reduce the financial burden on individuals seeking abortion services. A comprehensive universal health coverage program would ensure that all individuals and communities receive essential quality health services free of stigma with respect to human rights. Criminalization has led to greater costs for both abortion seekers and health systems. Immense resources are typically required for health systems to treat complications from unsafe abortion. And in comparison, liberalization of laws can generate financial savings at multiple economic levels. Studies have shown that restricting the availability of abortion based on or up to a specific gestation can have an impact on an individual's ability to achieve aspirational plans, have higher costs to health systems, and higher childhood poverty rates. Mandated waiting periods have also been shown to increase costs for clinics and the cost for services. So waiting periods can also result in unwanted or mistimed births. And in some cases, waiting periods also meant mandated multiple visits to the clinic, which can place a significant financial and time cost barrier to services. And finally, we're going to look at some of the key gaps in the knowledge base. So some of these things could be addressed in order to strengthen the evidence base, both from a disciplinary and methodological perspective. Although the economic costs of post-abortion care and treatment of complications from unsafe abortion are somewhat evidenced in the formal health sector, it would be beneficial to learn more about the economic factors of the informal sector, as many individuals are faced with the decision to seek services outside the formal sector when there are legal restrictions or barriers in place. The evidence we examined was dominated by studies focused on abortion provision within health facilities. Very few examined the economics of medical abortion outside of health facilities, and this is a critical area to address. A disproportionate amount of the evidence analyzed the cost of abortion services and policies at the microeconomic level, and a majority of these studies have occurred in high-income countries. As a result, more studies should be conducted outside of these high-income countries to get a greater depth of evidence. At the meso-economic level, evidence on the economics of abortion on communities is rarely reported. This lack of evidence does not align with the frequency at which abortions occur in communities, nor does it compare to the potential economic impact of unsafe abortion on communities. We also recommend that future research take more of an explicit economic lens on abortion access and policies. In unpacking the intersectionality of these economic factors, we can better understand the ways in which health systems and contexts reproduce injustices and inequalities. Great, thank you. Thank you all for joining us today, and thank you especially to our interpreters. I'd just like to open it back up to each presenter to see if you'd like to say anything to close us out today. Otherwise, we appreciate all of you for joining us today.
I just want to give a huge thanks to our co-presenters and collaborators on this project. It's been a really fulfilling project, and we really appreciate you joining us to present these findings.
If I have a final word, it is to say, just the enormous proportions of particular population groups that are completely excluded from the evidence base. Two at the top of my mind are people with disabilities and transgender persons, absolutely absent from the evidence base. So that's probably my final point, is we've got to be so careful about who continues to be made invisible and excluded.
I'd also like to, as my final point, and something I've written about extensively, is that reproductive rights and reproductive health are deeply entwined with economic empowerment in various dimensions. So if we are going to be talking about economic issues and women's economic empowerment, we must also be talking about their access to a complete range of reproductive health services, including access to safe abortion services.